Hello, everyone. We're happy to have each and every one of you here. So today we're going to have a presentation, which is going to be the second in our spine course series. So before we start, like we always do, we're going to go around and have everyone present themselves. I'll be calling out names based on how they appear on my screen. So the first on my screen is Asen. Can you please unmute and present yourself?
Hello, everyone.
Hi. Yes, go ahead.
Lunja, I'm a medical student in final year. Yeah. Hello, everyone.
Mm-hmm.
My name is Arsene Daniel Nyalunja. I'm a medical student in the final year at Université Catholique de Bukavu in the Democratic Republic of Congo. I'm also involved in global surgery, and I'm a member of AFAN. And it is a great pleasure to be a part of this panel today. Thank you.
Well, thank you. Thank you, my friend. Next up is Lorraine. Lorraine, can you present yourself, please?
All right. Hello, everyone. So my name is Lorraine Sibapela, and I'm a second-year medical student at University of Botswana. And thank you so much for having me.
Well, thanks for being here. And then Darwin.
My name is Darwin Chimba. I'm a fifth-year medical student from Copperbelt University, Zambia. I'm a member of the Association of Future African Neurosurgeons. It's a great pleasure to be here. Thank you.
Thank you, Darwin. Thanks for always being here. Next up is Zolo.
Hello, everyone. I am Zolo Ivan. I'm a CTA medical student from the University of Buea in Cameroon, Africa. I'm also a member of the Association of Future African Neurosurgeons, and it's a pleasure for me being here and to have you all with us tonight. Thank you.
Thank you, Zolo. May I mention that Zolo is equally in charge of communications and operations for the Association of Future African Neurosurgeons. Next up is Keke.
Hi, everyone. I'm Chuyu Keke. I'm a future medical student from the University of Zambia. I'm grateful to be a part of this great team. Thank you very much.
Well, thanks, Keke. We're equally grateful for you being here. Ndale. Ndale, if you're speaking, you're on mute. You need to unmute yourself. Okay.
Hello, everyone. My name is Ndale Genevieve, 40-year medical student at the University of Buea in Cameroon. I'm happy to see you today.
Okay.
Thank you.
Thank you. Thank you. Dr. Kabulo.
Thank you. My name is Kabulo. I'm from Democratic Republic of Congo. Currently, I'm final year neurosurgeon resident at the University of Zimbabwe. Nice to meet you all.
Nice. Always nice to have you, Dr. Kabulo. Next up, Dr. Kaduyu. Unmute. Yes. Yes, go ahead, Dr. Kaduyu. Oh, we can't hear you. I don't know why. Oh, okay. Sorry, Dr. Kaduyu, if you can hear us, we can't hear you, unfortunately. So next up, Dr. Kimani.
Hello, everyone.
Hi,
My
Dr.
name is Dr. Kimani from the University of Nairobi. I'm a third-year neurosurgical resident. Always a pleasure.
Always a pleasure to have you, always. Chimuka.
Hello.
Hi.
Hi.
Yes, can you present yourself, please?
I'm Chimuka Mlea. I'm a fifth-year medical student at the University of Zambia.
Okay, nice to have you.
Yeah. Oh, thank you very much. I'm happy to be here too.
Okay. Next is Nicola. Nicola Amisi, can you unmute and present yourself, please? Probably has issues. Okay, so finally I'll present myself. I am Ulrick Sidney. I am currently a research associate at the program in global surgery and social change, especially working with Global Neurosurgery Initiative. I'm originally from Cameroon, but I'm currently in Harvard, Boston. So today I'll be giving a presentation on the basics of imaging for the spine. So obviously this is not meant to be comprehensive. This is meant to help members, that is the future African neurosurgeons, to get the basic understanding of how to go about the imaging of the spine. Obviously, we know that for neurosurgeons, it's important to understand a lot of aspects, and one of those aspects is imaging. So for this purpose, what we'll be doing is we'll have a few slides, and we'll be very practical about it. If at any point there's any question you have, please feel free to raise your hand or send a message in the group chat so that we can address it. We want to make sure that this is not in any way pedantic. We want to make sure you get the most out of this and that you are able to apply this as medical students, especially. The residents we have here are all here to make sure I don't say something stupid. If I do, they will let me know that it is not right. So you're well guided. So let's start our presentations without further ado. Right, so this is, like we said, spine radiology 101. We'll be talking about two main modalities, the CT scan and MRI for the spine. Obviously, we know there's other imaging modalities, but we'll be focused on that. This is the plan we'll follow. The first topic is the anatomy of the spine and the spinal cord. There's no way one can read any form of imaging if one doesn't know the basic anatomy. From this basic anatomy, we are able to translate the basic anatomy into radio anatomy. And we can only do that if we understand basic anatomy and the principles behind each form of imaging. So I thought it wise to start with this, the basic anatomy. Sorry, just need to mute the person who's first. Sound, okay, okay. Right, so talking about basic anatomy, there's two main structures we need to focus on here. One of them is the spine, the other is the spinal cord. Talking about the spine. Now, we've all seen these beautiful pieces by Frank Nater, where we have here a lateral view of the spinal of the spine. And when we look at this lateral view, what we can appreciate from the get-go is these natural curvatures of the spine. So we have one curvature for the cervical aspect, which is which gives us this opening towards the back. So what we see here is it's convex from the front but concave from the back. And we see an alternation here for the thoracic segments. And then we get back to another alternation here on the lumbar segment. Generally speaking, what we're taught at in medical school is when we talk about the cervical segments, we have seven different vertebral bodies, so vertebrae. And then what we have for the thoracic is 12, generally speaking. Lumbar, we have 5, and then we have the sacral segment, and then the coccyx, which is a lot more variable. For the sacrum, we have 5 as well. Now, interestingly, there are a few variations in everyday life. So while this is what we're taught in medical school, we need to be aware that there's anatomical variations that are in no way pathological. So we'll stick first of all to the basics, which is this standard view. Now, when we look at the spinal column from an anterior-posterior view, here it's posterior, what we can see immediately is this spinal column for a normal person looks relatively well aligned. So we can see here from the spinal processes that they're all following a similar line. So again, what we saw here, although there was a curvature, you can see that there's an alignment for the normal spine. There's an alignment that one can follow. It's predictable in the way it is. And it's important to notice this and understand this, because then we'll be able to see certain anomalies on imaging of anomalies of alignments. So when we go forward, we're going to speak about this. And again, now it's important to go beyond just the fact of seeing vertebrae and knowing the differences between each levels or segments. Certain vertebrae are very special. When we talk about the special ones, the ones that come to mind immediately are the first 2 cervical vertebrae. Last week, we had a brilliant presentation by Darwin that gave us a lot of information about C1 and C2. So C1 and C2 are very special because C1, for example, has more of a ring aspect and doesn't get this standard quote unquote form for a vertebra. And C2 has this very prominent osseous projection that we call the dens of C2, or the odontoid process. Now, classically, if we're describing a vertebra, what comes to mind is this kind of a structure classically, but there's a few variations, like I said before. The few variations come from the fact that for the thoracic vertebrae, they articulate with the ribs. So they have articular surfaces for the ribs. But when we are at the level of the lumbar vertebrae, we don't have those facets for articulation with the ribs, for example. Another very important notion is when we're looking at the cervical and lumbar vertebrae, when we look at the space here that we call the canal or foramen, what we notice is it's triangular in shape for the cervical and lumbar, but it's a lot more round. It has more of a spherical aspect when we're thinking about the thoracic segments. Then equally particular here is for these different vertebrae, when we're talking about the different nerves, the nerve roots. Now, when we're talking about nerve roots, what happens is, and this is where a lot of medical students often get lost, we'll say, is that although we say the 7 vertebrae for the cervical segment, we actually have 8 nerve roots. So this is very important. First of all, very important to keep in mind, because when you're going to be reading those scans, CT scans or MRIs, you need to keep that in mind. So you have 7 cervical vertebrae, but you have 8 nerve roots. And the consequence is between C7 and T1, what you actually have exiting is C8. And that makes it in such a way that if you're going up, what you notice is above C7, you have the C7 nerve root exiting. But when you look at from T1 going downwards, it's from below the corresponding vertebra. So if I'm looking for T1, I look for T1 after the vertebra T1. But if I'm looking for C6, I'm looking for the C6 nerve root above C6. This is very important already. So keep that in mind. You have 8 cervical nerve roots, but you have 7 cervical vertebrae. And that makes a change, a difference. That makes equally a difference in how in the symptoms that you'll be able to find in the patients, and how you correlate those symptoms with the level of the lesion. So Another thing we can appreciate here is anterior to the to our vertebrae, we have a ligament that goes in front all the way from the top to the bottom. And logically, you would expect the name of that ligament to tell you exactly what it is. Like we described, it goes from the top to the bottom. It's anterior, so it's a longitudinal ligament that is anterior. So it takes that name. And behind this, the vertebral body, we have a posterior ligament, a longitudinal and posterior ligament. So we have one that's anterior, another one that's posterior. So anterior to the vertebral bodies and posterior to the vertebral bodies. So the posterior ligament and the posterior longitudinal ligament will be here, posterior to the vertebral body. The anterior will be here. Now, here at the back, what we'll have is a yellow ligament, and yellow takes the name flavum. So it's the ligamentum flavum. So we will find that there's equally other ligaments, and they take the names as they take the names of the structures they touch or what they do. So you have a ligament between the spinous processes. So the spinous process is this, right? The process that comes out of the spine from anterior to posterior. And so you have a spinous, an interspinous ligament that will be connecting the different spinous processes. And it takes that name exactly as you would expect. So another thing you will notice when we'll be looking at the imaging is lateral to the spinous processes, because we have gaps here, we'll be able to distinguish various paraspinal muscles, and we'll be defining some of them. Equally important is this process that goes to the side. It goes to the side, so it's transverse. So it's a transverse process. So spinous process, transverse process. Now there's some bone that links the transverse process to the spinous process, and we call that a lamina. So logically, this lamina will be very, you need to get used to its shape, its function, and its surgical anatomy, because you'll be used to it in surgery, in spine surgery. You will hear, for example, of a laminectomy, which is literally ectomy, taking out the lamina, laminectomy. So this is what we mean when we say we're taking out the lamina, and you will understand why. Why would you need, for example, why would you need to take out the lamina? Now, look at this canal. This canal is made of bone. So whatever exists in this canal should only, because bone is inextensible, so it shouldn't go above this limit. And if anything increases the pressure inside, because there's something occupying space, the things that are inside here, we'll describe them. The things that are in here will have to give way. The one who's weakest or soft or less resistant will have to give way to whatever the process is in here. So one of our solutions for surgery is to create more space. And one way we can do that is to take off a little bit of the lamina to give some space for the lesions to be able to expand without issues, without compressing what is inside. So equally important is the pedicle. The pedicle is equally important in surgery when we speak about screws, for example, where we're trying to put screws. What you're doing in effect is you're going to drive your screws through here, through the pedicles, to find themselves, to nest them in the vertebral body. So as a recap, this is our vertebral body. These are the pedicles, these are the laminae, and the laminae here are a link between the transverse process and the spinous process for each side, while the pedicles are a link between the vertebral bodies and the transverse processes. So we have described this from this superior view. Now, when we look at a spinal column, a spine here, from the side, what can we distinguish? We can see our vertebral body here, and here we can see what is more prominent here is the transverse body, right? And we said between the transverse body and the vertebral, the transverse process I meant, and the vertebral body, what we have is the pedicle. And here what we have is the spinous process. So it's more difficult here to see the totality of the lamina, for example. But we appreciate between the two vertebral body, we see some cushion-like structure here. This cushion-like structure is the intervertebral disc. And the intervertebral disc has two basic structures. We have a nucleus in the middle. It's called the nucleus pulposus. And we have a ring that's fibrous, so it's called annulus fibrosus. The names already tell you what they do. And this will be important because as we can see here, as we can appreciate here, we have a notch at the bottom here and a notch here superiorly. And this gives a sort of an aperture, which will later on give way to the different nerve roots we're talking about. And as a consequence, if anything happens to this disc in such a way that it moves towards the back, there's always a chance that this disc might impinge whatever nerve root is passing here. So here we can see a correlation, an anatomical correlation between the intervertebral disc or diseases of the intervertebral disc and whatever structures go through here. And we will need equally to appreciate this on the imaging. Now, yeah, let's go ahead and then we'll see what we can add. We'll see all of this on the MRI. Again, this is meant to be a quick summary to get everybody on the same level before we start the more nitty-gritty imaging. Now, we're looking at a spine here, right? So a spine is part of the central nervous system, and it extends here. What we have, this is the posterior fossa, and we have here from C1 to C8. Notice what we have here. This is C3. Above C3, you have the nerve root C3. But from T, as we said before, it's below the vertebral body and it goes down. Now, another thing we appreciate is the central nervous system, in effect, ends. We often will say it can be 10% usually in the inferior aspect of L1, 10% in the superior aspect of L2, but often L1, L2. And because it ends here, well, the nerve roots still need to go all the way and exit where they should be exiting. Now, why is this equally important to appreciate? First of all, how does this come about? This comes about because our spinal cord stops growing while we continue, we keep on growing. So imagine the spinal cord you had when you were little and you growing in terms of height. Because you're growing in terms of height and your spinal cord is not growing, your nerve roots still exit where they're supposed to exit, but they have to do all these long, they have to go through all this long and windy trajectory. And equally important to appreciate is these nerve roots do not exit perpendicularly. They don't go like boom and go straight across. They exit well above, and then they go sort of vertically before they can go horizontally. As a consequence, diseases above the level of exit can affect the nerve root. So take L2 here. If we trace back L2, we can see that a disease at the level above L2 can definitely cause manifestations on the L2 level, and so on and so forth. So what we have here is the end of the spinal cord, and now we have these nerve roots that go down. Because these nerve roots look like the tail of a horse, we call it cauda equina, which literally means that it's a horse tail, literally. So you can hear, for example, of a cauda equina syndrome, which will be literally the manifestation of a disease affecting this horse tail, in effect. You will often be asked to distinguish between diseases of the conus terminalis and diseases of symptoms or affections of the conus terminalis of the medulla and diseases of the cauda equina. What you can see clearly here is this is not part of the CNS. This is peripheral. However, this is central. Because this is central, you have a manifestation that will let you know you have an affection that is touching the central nervous system. In effect, what you will have is things that are extra pyramidal, as in with the Babinski sign, for example. But here you wouldn't have that manifestation. It will only be a peripheral neurogenic syndrome. Going forward now, we've brushed on the anatomy. Now, what's the science behind the imaging, behind X-rays, CT scans, and MRIs? We lumped up X-rays and CT scans together. Why? Because what we use to do our X-rays and our CT scans is electromagnetic waves. Not any kind of electromagnetic waves. You will all appreciate and remember this spectrum. Where we are is here. So we have ionizing radiations. These ionizing radiations go through matter. And when they go through matter, what happens is we have a detector on the other side of that matter. The detector will in effect pick up only the rays that were able to go across the material. So if the material is able to absorb or attenuate all the rays, the detector doesn't get anything. If, however, all the rays are able to go through, the detector catches everything. And then what happens is the detector sends the information for the case of CT scan to a computer. And this computer will try to translate this attenuation into, oh boy, we're being photo. There's someone.
Yes, I think it's Shlen Gililo, I think so.
Mm.
Yeah.
Yeah, sorry about that. Right. So when we're talking in terms of attenuation, the computer translates this attenuation in what we call units of Hounsfield or Hounsfield units. Hounsfield was one of the people that described this. And it looks like this, where we have for maximum attenuation, you have metal, calcium, and you get a lot of calcium in bones, right? Because you get a lot of calcium in bones, you get this density, because that's the terminology we use. And these are the Hounsfield units. If it goes through air, this is what you get, this kind of an appearance. So in effect, it translates into densities, and these densities give us an idea of what the matter should be like. Now, what's the science behind the other form of imaging, MRIs? MRIs use big magnets. And what these big magnets do is they will make protons move. If you remember, hydrogen, when it's ionized, is in effect a proton. So what you're doing is you're going to align the hydrogen atoms, you're going to excite them, and then you're going to relax, let them relax, and they will release energy. So the different phases, the different forms of MRI play with this fact. They play with how much relaxation you get. They play with how much phasing or dephasing you get, and depending on the axis. So a structure that has a lot of water, for example, water is H2O. That such a structure has a lot of H, so a lot of H plus. And so such a structure is more likely to be seen on an MRI. A structure that lacks a lot of hydrogen atoms or water will be less likely to be seen. And logically, you get the understanding that if you're thinking about a structure that has a lot of bone, calcium, not enough water in it, that kind of a structure is not the best structure to be viewed on an MRI. But if you're thinking about the same structure and you go for a CT scan, well, you will probably be able to distinguish a few things on that CT scan that you weren't able to distinguish on an MRI. However, soft tissue in general will be well appreciated on an MRI because soft tissue, unlike bone, contains a little more or maybe much more water or hydrogen atoms. But even if it's not water, you can think about fat as well. So fat, remember your organic chemistry. Organic chemistry was essentially carbon and hydrogen together. Carbon and hydrogen with oxygen or nitrogen or sulfur, but always carbon and hydrogen. So things that contain a lot of hydrogen are quite good for visualization on an MRI. So keep that again in mind, keep that in mind. So what we do here is we give it energy, with a large magnet, and what we get back is an intensity. Remember, with the CT scan, we spoke of density. Here we're talking about intensity or signal. Now, these intensities will give different signals depending on the kind of MRIs we're doing. And we'll see some of the important ones, T1, T2, and STIR. We'll see what all of these are. Now, for a medical student, it's very important to be able to appreciate when you're given imaging, when is it a CT scan, when is it an MRI? Because for a medical student, it might all look the same. It's all black and white. Well, the first thing we're going to say is, remember what we said so far. With the CT scan, what we were doing was we're using X-rays, and we were letting the X-rays go through material, and material like bone and metal would attenuate enough, and we're speaking in terms of density. Whereas when we went with material that wasn't able to attenuate, like air, we're going to get all of the rays to go through, and it was dark. With the MRI, we said, well, you won't be able to visualize enough of the bony structures. However, you will be able to visualize the soft tissues. So keep that in mind. Let's keep that in mind for the moment. We've described a few things already. We've described T1, we've just spoken about it. We're going to go further into this, T2 and STIR. Okay, so what do we understand by T1 and T2? Remember what we said for MRI was, we have a big magnet. That's essentially what it is. And this magnet generates a magnetic field. When it generates a magnetic field, what we're playing with is a variation between recovery and decay. We keep giving it energy, we align all the atoms, and then we let them go. That's what we're doing mostly. So with T1, the lipid is, like you see here, is hyper intense or gives a hyper signal. So it tends to be white, okay? Water or CSF or edema tends to be hypointense. Bone is hypointense in all the others. Now, when we say lipid is hyperintense, when we say it's hyperintense, what you should translate is not just think lipid as in just that way. So which are the anatomical structures in your central nervous system, your peripheral nervous system that have lipid? Remember the matter, gray matter, white matter. Why is the white matter white? Well, the white matter is white because it contains a lot of myelin sheath, right? And this myelin sheath, if you remember your biochemistry, is essentially lipids, sphingomyelin, for example, because it's basically the membrane of, in certain cases, oligodendrocytes, in other cases, Schwann cells. Because we are talking about the central nervous system, when we talk about central nervous system, we see oligodendrocyte. When we're talking about the peripheral nervous system, we think about Schwann cells. And the membrane of a cell, the bilayer, is phospholipids. So it's lipid, remember that. So white matter, lipid. So white matter will be white on T1, hyperintense. However, gray matter contains a lot less lipid. So gray matter will tend to go towards the hypointense. But you will flip that if you're on T2. You flip that because now you have less hyperintense lipid, and you have a hyperintense CSF. So what that means is, if you took gray matter, white matter on T1 and gray matter, white matter on T2, you have a switch where one is hyperintense, the lipid for T1, so that is your white matter, but it will be hypointense in T2. Okay. So another thing that is interesting to know is STIR. So STIR stands for short toe inversion recovery. STIR is actually, it builds off of T2. So it's a type of T2. It's a type of T2 in which what we've done is we're eliminating the lipid signal. We're taking out the lipid. And because we're taking out the lipid signal, we're able now to distinguish adequately between things that are more watery in nature and things that are more lipid in nature. We're eliminating a lot of the lipid signal, and we're remaining with the liquid signal. And because we're remaining with the liquid signal, we can say for sure that, oh, for example, this contains a lot of water. And in which cases do we have a lot of water abnormally? Well, edema. Remember the central nervous systems, you have different types of edema, vasogenic edema, cytotoxic edema, interstitial edema. Now, so when you have that edema, what you can do is, if you're doubting between simply edema and on the other hand, a lipid, you can use stir, and that tells you, there's edema here. And that points towards a certain number of diseases. When we talk about the next one, which is post-contrast. Now, post-contrast, break it down, post-administration of a contrast. Here, the contrast is usually around the family of gadolinium. So we administer a substance that, when given, will go and enhance the abilities of tissue. So this contrast will make it in such a way that structures that were not properly seen before are more likely to be seen. So this happens often when structures had the same form of intensity, for example. So if you had two structures that you couldn't distinguish because they were giving you the same signal, the same intensity, administering a contrast, if there's a difference in how they take up this contrast, can give you this difference. But another thing the contrast can show you is the vessels. The contrast can give you an idea of how vascularized a structure is. And equally, this notion of vascularization can give you an idea of what kind of a pathology or disease it is. So in the basic definition of a cancer, you know, a cancer is this anarchic growth of cells. And this anarchic group of cells tends to have neovascularization and hypervascularization. So those are elements that you look for when you're thinking, might this be a tumorous or cancerous growth? Those are the kind of elements you'll be looking for. If there's an inflammation as well, you think about that. Remember the different processes of inflammation. You have vasodilation in inflammation, and that vasodilation will manifest, again, thanks to your knowledge of what a contrast does and what basic physiology is like. So these are some of the basic imaging modalities. We'll be focused mainly, because this is the basics, on CT, T1, T2, and STIR right now. The other ones, you can read them, diffusion-weighted imaging, for example. So now we'll pop out of here to a resource I feel is probably one of the most interesting and useful resources today on the internet, Radiopedia. You should make this a habit. If you're thinking about learning anything radiology related, always go to Radiopedia. It's a free website and it gives you really fantastic imaging. So let's try this now. We're going to take a look at a normal X-ray CT scan and a normal MRI. So I will share the screen. Let's do this. So this is what the website looks like. Here, you can all access this website, obviously. So what we see here is an X-ray, a simple X-ray of the cervical, and part of the cervical and part of the upper part of the thoracic. Now, one of the questions we asked ourselves was, how do we know the difference between, on the one hand, the CT scan, and on the other hand, the MRI? Now, take a look at the definition of structures on this image, and take a look at the definition of structures on this other image. So it is clear, you see so much more, you have so much more detail on the bony structures here than you have on the other one. You have little or no information about the soft tissue structures. So you can clearly see here, not only can you see the external aspect of the bone, you can equally see the trabeculae inside. You can see really good detail of the information, which is not the case here. Here, however, you can tell so much. You can see clearly here the CSF, and this CSF tells you, well, you're in the subarachnoid space. What you can see here clearly is the spinal cord. You can even distinguish some vessels here and some paraspinal muscles as well. So it is it is something that should be easy for you, clear for you to make the difference between a CT scan and an MRI, whichever the MRI, whichever one be the CT scan, whatever the structure is. Now, you've seen this. Now let's try and describe the different things we saw on the anatomy from Frank Nater and here right now. So I'm going to take a sagittal and go through the different cuts. Let me take this out and see if we can recognize certain structures. Now here, this is a C2 with the odontoid process. We can see C2 here articulating with here C1. So here we have foramen magnum. And because C2 is very particular, this is one of the ways you can label vertebrae, because that's very important. You need to be able to label the vertebrae and know what level you are at. And one of the ways is to find C2, and it's famous on the odontoid process. And because I know this is C2, I then know that this is C3, C4, C5, C6, 7, 8, and what did I say, 8? C7, T1, T2, T3, okay? And these are the spinous processes. These are our spinous processes here. So here in the middle, what we have actually is our foramen. So what we know is what we know should be in the foramen is the spinal cord with the meninges. In the meninges, you have the pachymeninge or dura mater, and the leptomeninge, which is 2 layers, pia mater inside, and the arachnoid. Now, between the arachnoid and the pia mater, you have the subarachnoid space. And in the subarachnoid space, what you have is CSF flowing. So you can't even tell that here. You can't distinguish here. Someone with more experience probably will be able to see a few things, but you can't distinguish that here. If you came on the MRI, however, you can appreciate C2 here. You can appreciate C2 here. Dr. Kaduyu sent me spinal canal. Sorry about that. Yes, spinal canal. So you can appreciate C2 here. So this is C1, and here we have our spinal canal, and here we have our spinal cord. So this is CSF here. So now that we've said, okay, this is an MRI, the next thing we want to do is we have to ask the question, is it a T1, is it a T2? Remember, in T1, lipid is hyperintense. So what you can do is lipid is hyperintense, and liquid CSF edema will be hypointense or give you a low signal. Here you can clearly see, look at the CSF. This is not a low signal, this is a high signal, right? So this is not a T1. So the other thing, we're going to look at T1, T2, and stir. So again, this is a normal CT scan for the cervical. This is a normal MRI for the cervical, okay? Now, getting back to, okay, how do we actually read the, let's keep going. Right, so spine imaging, what are we actually looking for? We have this from an article. I'll be sharing the link at the end. And these are the elements we want to be studying. And when you look at these elements, you can have the different diseases. You can have different diseases for each of them. So vertebral alignment, one of the common diseases that we find with vertebral alignment, whether you are in the sagittal or you're getting coronal, for example, so with the sagittal, when you're taking the sagittal, you'll be appreciating things like movements in the anterior posterior cuts. So those kind of movements will give you things like lordosis or kyphosis. If you're looking at coronal, you can appreciate movements that are lateral, that is the scoliosis. If the lateral movement goes towards the left, you call it a levorscoliosis. If it goes towards the right, you call it a dextroscoliosis. But another kind of movement you can have is a movement of a vertebral body over another vertebral body. Remember we said, although there's natural curvatures, normally you should be able to get an alignment between the anterior aspect of the vertebral body and the posterior aspect of the vertebral body. if you don't have that alignment and there's one that is moving in front of the other, what you have is some kind of a step-like aspect. That step-like aspect, in effect, is what we call a spondylolisthesis. And there's different grades of spondylolisthesis. So it's very simple. From 0 to 100, divided into 4, 0 to 25, grade 1, 26 to 50, grade 2, and so on and so forth. So, and that is easy to appreciate if you're careful when you look at your, that's easy to appreciate if you're careful when you're looking at your imaging. So spondylolisthesis. Again, this is, if there's any questions, please send them my way. So you come on Radiopedia, you're going to find the imaging, and let's look at this. So we're looking at the anterior aspect of the vertebral bodies here and the posterior aspect. This is somewhat predictable, right? And what we can see here is a step-like process, a step-like aspect. So here there's a break in that curvature. And now, because there's a break in the curvature, we say, there's something going on here. It's a spondylolisthesis, but we can't stop there. Now we need to describe the spondylolisthesis. Is the movement towards the front or towards the back? How do you decide that? Well, you look from, based on the inferior, you describe the displacement of the anterior, of the superior the vertebral body. So the vertebral body here has displaced itself anteriorly when you compare it to the inferior vertebral body. So this is an antelisthesis. If this was behind, we'll have said it's a retrolisthesis. And the next thing we want to do is we measure this displacement. What percentage? So when you're looking from here, if you're going to say from 0 to 100, what percentage is it approximately in displacement? We can say here roughly, we should be around 50%, ballpark, around 50%. So this is a grade 2 antelisthesis, right? So you can see this here. Obviously, some of them will be much more subtle, and you'd need some measurements to find out. Why is this important? Why do you need to learn about these? Well, when you're looking at when you're looking at the continuity between the posterior aspect of the vertebral bodies here and the anterior aspect of, there's a message, sorry. Oh, okay. Just a second, please. We have to deal with thanks, Zolo. We have to deal with people coming in to cause trouble each time. Right. So what happens again is, remember, as the way we described, we said this space here is very limited, it's very rigid, and this space contains very fragile elements. What did we describe in here? We said we had the meninges, we had our spinal cord. So if anything comes in here, the first things that will be under duress here will be a spinal cord, a nerve root, and the CSF. Now, the CSF might move towards the head, for example, but at one point, if it's too important, the next to suffer will be the nerve roots as well as the spinal column. Well, this is really below, so we don't expect the spinal column to be suffering. However, we will expect the nerve roots, because remember, the spinal column would end around L1, L2. So depending on what level we can see this, we can anticipate certain things. We can anticipate certain aspects to a certain symptomatology. That's the word I was looking for. So say, for example, you have such a lesion at the level of at the cervical level. If it's a level of C2, C3, very high, because it's C3, well, you know, C4 usually, very often, will send a branch to the diaphragm. So that's a patient, for example, that will have difficulties breathing. You know that C5, C6, C7, C8, and T1 go to the upper limb, and so you will have paralysis of the upper limb. But you equally know that it won't be the brain won't be able to send nerve impulses all the way down to the lumbar segment. And if it doesn't go to the lumbar segment, that person will be paralyzed at the level of the lower limb. So this is a person that will have paralysis of the forelimbs and a paralysis of the diaphragm as well. So that's what you'll be worried about. However, if it's below, say it's below C4, C5, probably not a problem with the diaphragm, but there's problems with other things and so on and so forth. So you only understand that because you know already the anatomy, the physiology, and you translate that with the imaging as well. So for our patient here, now what we can say here is it's lower lumbar here. So we're not expecting anything too crazy in terms of paralysis of all the limbs. So one of the things I forgot to say was when we are counting the vertebrae, so one of the ways we said was one, the odontoid process. The other way to do it is you look at the vertebrae that are articulated to the ribs. The vertebrae articulated to the ribs will be in effect the thoracic vertebrae. And the last one to articulate with the rib will be T12. From that one, you can use that to count down. Another way people often use, but which is very questionable and you can find yourself in problems, is to identify the articulation of L5-S1. Now, this is a problem because sometimes the S1 vertebrae can actually look like an L5, and sometimes the L5 vertebrae can actually look like an S1. So that's what you talk of sacralization and lumbalization. So this is, you want to be careful with that. Although you can identify, you want to be careful with that. So one of the almost certain ways is you want to identify the odontoid process, but that means you need to have the cervicals. And another way you want to do is you want to identify T12 by checking the vertebra that's articulating with the last vertebra articulating with a rib. That way, at least you're more likely to find the right articulation. So that was one of the things for the alignment. Another alignment, but disease of alignment we spoke of is scoliosis. So scoliosis, well, you've probably heard about it and seen it. So like we described, let me take this. This is a simple X-ray here. So clearly you can see here that the spinous processes are not aligned. You can clearly see that the convexity is leaning towards the right here. So you can clearly see here that it's not aligned. So this is a deformity of the spine, and there's some complex spine surgery we can do to try to correct this. And before correcting it, what can be done is, what should be done is you want to measure by how much the scoliosis is deviated. So you can use the Cobb's angle. So what you do is you get the inferior, the line parallel to the inferior aspect of the superior cervical vertebral body, another line that is parallel here to the superior aspect of the inferior vertebral body. Then you take orthogonals to these, and then you get the angle. So that gives you the Cobb's angle. That will help you determine by how much you can do. You should do your correction before expecting before expecting a good quality of life for your patient. So one of the things that can cause this scoliosis is hemivertebrae. So you will often see these hemivertebrae. So another one, we spoke about vertebral alignment. Another thing we want to talk about is vertebral height. So vertebral height increases gradually from the cervical all the way to the lumbar. So as you're going down, it is increasing really slightly, so much so that if you're looking adjacent vertebrae, you shouldn't see too much of a difference. It shouldn't be too noticeable. However, if you notice a vertebrae below another is shorter in terms of its height, then there's probably a problem. So one of the things that can be the reason that can be the cause there of the shortening of the height of the vertebral body can be a fracture, a compression fracture. Compression fractures, we can describe wedge fractures, wedge fracture of the spine, which is anterior. Yeah, let's take this and show here. Now, let me see if I can blow this up. I think I should be able to blow this up. Oops. Sorry, let me try and blow this up. I hope everyone can see this. So here, this vertebral body here, what we see is it's supposed to be the same height anteriorly and posteriorly, but what we can clearly see is anteriorly it's shorter. The anterior height is shorter than the posterior height, and because this is shorter anteriorly, we call this a wedge. So it's a wedge fracture. We can have the same thing, but posteriorly as well, in which case we'll call it a crushed fracture. So if it's anterior wedge, the way I remember it is wedge is sort of like W is like A, but you put it upside down. And then when it's posterior crushed, you could use a C to write a P. So those are the ways I use them to remember this. Another thing we appreciate here is the disc height. So the disc height is interesting because that is in effect the intervertebral space that we're studying. So the intervertebral space will give us an idea about the disc height. If it's a CT scan or if you have an MRI, you can actually appreciate what the intervertebral body looks like. So here we can describe displacement of disc. We can describe displacement of the nucleus pulposus. If you remember, we said we have the nucleus pulposus surrounded by the annulus fibrosus. Now the nucleus pulposus can move, and when it moves, what happens is it can go backwards, and if it goes backwards, it can impinge. So what we will be looking for right here is, here we have the vertebral body here, and we can see this signal here, a very low intensity signal, which is not meant to be here, which is actually adding to this curvature. This is what the vertebral body should have been like. This is what I'm demarcating here. But clearly you can see it's going above this limit here. There's a dark line here, and it's finding itself in the spinal canal. And as it's finding itself in the spinal canal, it is pushing the structures in the spinal canal. Here you can see in the middle here. So there's a mass effect. So there's two terminologies you want to be used. You want to be able to describe easily. It's disc protrusion and disc extrusion. So we speak of disc protrusion when the diameter of the nucleus pulposus. So what you're doing is you're measuring this diameter and you're measuring its base, basically. So when you're measuring the base and you're measuring this can give you an idea of when it's a protrusion and when it's an extrusion. So if the diameter of the material is inferior to its base, its implantation, then you say it's a protrusion. If, however, it's superior to the implantation of the base, then it's an extrusion. Another thing that can happen is it can actually not be in contact anymore with the rest of the intervertebral disc here, in which case you say it's a sequester. And that sequester can migrate in the spinal canal. So you can find it equally in other forms of imaging. So this was axial. If we're looking at a sagittal of any case here, we should be able to see the same things. So let's appreciate this from the top to the bottom. So let's follow. Already here you can see a rectitude here of the spine. So as we're going down, okay, what we're going to notice at this level, just take a look at the levels above and then take a look at this level and at this level. So clearly what you can see is there is this hypointense signal here, this hypointense signal that is pushing the cauda equina elements of the nerve roots here behind. So you can see it. Look, if you check the CSF fluid, check the CSF, and you can see clearly that there's an abrupt stop here. So you can see that there's that effect pushing towards the back. So it's equally easy to appreciate if you're very if you're very systematic in the way you do this. So first thing, as a reminder, we talked about vertebral alignment and diseases we can see when there's problems with the vertebral alignment. We spoke about the vertebral height, where we spoke about wedge fractures and crush fractures. Now the disc height and its signal. So another thing that is very important to appreciate in reading this is in the spinal canal, the elements that are not supposed to be in the spinal canal finding themselves there. So what are those? Well, you need to know the different compartments of the spinal canal. Remember that in the center, what you have is the spinal cord, and that spinal cord, being central nervous system, has multiple layers of meninges. So directly in contact with the spinal cord is the pia mater. Between the pia mater and the arachnoid, you have CSF, and that is actually the subarachnoid space. Above the pia mater, above the arachnoid, above the arachnoid, what you have is the dura mater. Now, between the dura mater and the arachnoid, it's a virtual space. That space is not supposed to be occupied. It's not supposed to be. But if, however, you have elements that find themselves there, you will be describing those elements based on that space. Now, above the dura mater, you have structures around the dura mater, and anything that finds itself around that dura mater will be said to be extradural or epidural. So because of these different spaces, we can speak of three major compartments. If something is outside the dura mater, it's epidural, extradural. If it is inside the dura mater, but not in the spinal cord, you will say it's intradural but extramedullary. And if it's inside the spinal cord, it is intramedullary. And one way to think about this and what you should be seeing there is just to know what is supposed to be there in that normal space. So out of the dura mater, what you find often is fat deposits. So these fat deposits can be in the form of lipoma or multiple lipomas. This is a lipomatosis. You often see the lipomatosis in patients who have been consuming steroids. So professional athletes or athletes at any level who are doping with steroids. So you can find those. Another thing you can find epidural or extradurally is abscesses. And so one of the common ones in our context is Pott's disease, which is the tuberculosis that you find on the spine, right? So you can find an abscess. You can equally find a hematoma. We just described, for example, herniated disc. So this ligament hypertrophy, for example, for the ligamentum flavum, which is at the posterior aspect of the spinal cord. So you can find this as well, and a hypertrophy of the ligamentum flavum. Osteophytes are little beaks of bone. So we'll see this when we'll be looking at degenerative spine disease. They actually look like the beak of a parrot. So you can find them if they're on the posterior aspect equally in the canal. Or you can find these more rare lesions, which are like other forms of cysts. Now, if you're talking of intradural but extramedullary, so what you're seeing here in effect is something that is linked with cells or tissue that is in this space. In this space, what you have is the meninges, and the tumor of this meninges is what we call a meningioma. So obviously, intradural, extramedullary, one of the things you want to think of is a meningioma. Ependymoma, because ependymal cells, if you remember, have play a great role in CSF fluid production. So you will find them, for example, all the way in the center of the spinal cord, because in the middle of the spinal cord, you have some CSF that flows through, and equally outside, that is in the intradural extramedullary, which explains why you can see ependymomas in the intradural extramedullary space and equally in the intramedullary space. Now, when you're talking of intramedullary, one of the obvious ones is tumors of the nerve, the supporting nerve cells, that is the glia. And the glia, when they have a tumor, it's called a glioma, right? One of them, there's a whole classification for these diseases by the WHO, which Dr. Kabulo presented brilliantly, I think 3 months ago. So you would be expecting gliomas or astrocytomas. Other lesions you might find are hemangioblastomas and cavernous hemangiomas. So let's try and see what let's try and see some of these lesions on Radiopedia. Now, for the extradural, we spoke of abscesses, Pott's disease, for example. So Pott's disease, which is one of the manifestations of metastatic tuberculosis, in this case affecting the spine. So here, this is a CT scan that we have. Now, so what we're doing here is, let's follow this. So what we have here is the vertebral body. Okay, so this is a transverse process. This is the pedicle here. So when I'll look for an image equally where we put some screws. So when we put screws, what we're doing is we're going this way. I'm putting a screw. We're going this way. I'm putting a screw. And then this is the spinous process. Here, this is the lamina or lamina. So let's keep going down. Okay, so right here, it's not the clearest. So there is a shift in density around about here. Let me see if I can get an MRI to show you all this. Is this the MRI? Yeah. Let's start from the top. I hope you will be able to appreciate the change. Okay, so let's do this. Even if you're not used with radiology, so just look at the anatomy here. What are you supposed to have here? So here we're clearly in the thoracic region. This is at the lung fields here. We're supposed to have a vertebral body here. We're supposed to have here, obviously, the ribs, transverse process, and spinous process here. Now, just focus here. When you see it, this is what it should be like normally. Well, it's not normal still. Okay, so this is approximately what it should be like normally. I'll be going up, and then you appreciate what's happening. Right, so each time you're taking such an image, so what you want to do is recognize the normal structures first. Don't try to diagnose a disease at inspection. Try to be systematic. Can you distinguish each of the structures that are supposed to be there normally? Next thing is, if you're distinguishing those structures, do they have the signal they're supposed to have? What is meant to be the signal of bone, for example, on an MRI? What is meant to be the signal of CSF fluid? What is meant to be the signal of the spinal cord? You do that stepwise, and if you keep doing that, you will notice that it's easy for you, even if you don't find the disease, to say, okay, there's something here, and you can attract you can attract their attention or your attending's attention. So clearly, what we're seeing here is we're supposed to have, like we said here, a rib that's articulating here, and we're supposed to see the entirety of our vertebral body here, but there's some process going on here all together. So we have to ask ourselves some questions. What is happening here? There's a number of things you can think about. Obviously, we're not in the differential diagnosis. I know you know already that it's a Pott's disease, but you're supposed to go through a list of questions. What can this be? What kind of lesion can this be? Is it a lesion that's related just to the vertebral body, or maybe to the rib, or even possibly to the lung fields? And that way, step by step, you come to a diagnosis. But what is important for us here is we're looking in the spinal canal. Each time there's a lesion in spinal canal, what you want to determine in the first place is, does this lesion in any way communicate with the CSF, or is there a clear distinction, a clear limit between the lesion and CSF? That's the first question. Because if you can ascertain that the lesion is not communicating with CSF, then you can say, okay, this lesion is extradural. However, if the lesion is communicating with CSF, then you find yourself saying, okay, if it's communicating with CSF, is it in contact with the spinal cord? If it's in contact with the spinal cord, it brings other questions. If it's not in contact with the spinal cord, you're saying, okay, this is intradural, the extramedullary. So be systematic. Always ask those questions and find those distinctions. The other one we spoke of is, oh yeah, let's find a meningioma of the spine. Meningioma of the spine, meningioma generally is, oh, did I write that wrong? Spinal meningioma. So meningioma of the spine is equally important because there's a few things you want to know. Obviously, the classical dural tail sign, vascularization of this. So let's forget the lesion first. Okay, so here apparently no problem with the alignment. Okay, no problem with the alignment. We're looking at, let me go window by window. Oh, this. Right. So how did we say we're going about this? Here we find a lesion. This lesion is, oh, come on. This lesion is here posterior to the vertebral body, right? Okay, now it's posterior to the vertebral. Oh, sorry. Now it's posterior to the vertebral body. What we're going to do is let's check the CSF. Look at the CSF. And looking at the CSF, you want to know, is there a stop in the flow of CSF? Can you see the CSF going? Oh, can you see the CSF keep flowing? Why is this moving? Can you see the CSF keep flowing beyond this? Yes or no? Based on that, you'll be able to know if it's extradural. And then clearly what we see here is an abrupt stop, an abrupt stop. Next thing you can see here is this implantation that gives it a tail. There's a tail up here, a tail down here. It's very classical for meningiomas. So this gives us this makes us think high suspicion of a meningioma in this case. So another thing you can have obviously is a lesion which is not stopping the CSF. And if it's not stopping the CSF, you know that, okay, right now it's not stopping the flow of CSF. If it's on the other side of your dura mater, you're saying, okay, this is probably a lesion that could be either in the spine, spinal cord, which case intramedullary, or it's inside and it's intradural extramedullary. That's the word I was looking for. So here we have a lesion that is intradural extramedullary. It's stopping the flow of CSF, but if what we need now is the coronal views to see what is its interaction with the spine itself. Let's see if we have axial view. So what we're doing here is look at this where we have that center here. So round and round. So okay. Spinal cord here. We're following. So there's a signal. We want to look at the signal of the CSF and the signal in the middle. I don't know why this thing keeps moving. Oh. Why is this moving? So we're looking, oh, yeah. So we're looking at the signal here. We're looking at this signal, and we're looking at signal outside. What we want to know is the interaction between the different signals, and we have to follow it and see whether there is there's a direct link between the extra medullary, the medullary compartment and the intramedullary compartment. And clearly here we can see that, okay, here we can clearly see the limits. Right? We can clearly see the limits here. You can clearly see limits here. Okay. So I think that's about it. If I've made mistakes, please, Dr. Kaduyu, Dr. Kimani, correct me. And Dr. Kabulo, obviously.
No, Sydney, the presentation is very nice, very good. Quite a refresher for some of us.
Thanks. I'm waiting for your feedback because we have to improve, obviously. Dr. Kabulo, please share it.
Yes, Dr. Ulrick, are you done?
Yes, yes.
Thank you so much for the very brilliant presentation. Let us give chance to medical students with us here. If they have questions, then I'll give my comment at the end.
Okay. So if there are questions, please go ahead, ask your questions.
Feel free to ask questions.
There's always two things when people don't ask questions. Either they understood everything or they understood nothing. Whichever one it is, it's scary. I doubt everyone understood everything. So please feel free to ask questions. Okay.
Okay, thank you so much. If there are no questions, that was perfect, Dr. Ulrick. Congratulations. We really enjoyed your presentation. We were like revising also things. That was great. I wanted just to give a comment about spondylolisthesis.
Yes.
Okay, there are many classifications. You mentioned one, and that one I wanted just to add. You said there are four grades. Now, actually, it's 5.
Okay.
The classification you use. We are not going to mention others. We are just focusing on this one. There are 5 because when you get now complete with 4 of the vertebra, that's now spondyloptosis. It's now grade 5.
Thanks.
Yes. And yeah. And the CT scan you showed on the spondylolisthesis, that was a nice one, showing a spondylolisthesis grade 2, like you mentioned. But there was, if you check very well, clinically that patient doesn't have signs because there were fractures on the posterior element. The pedicule was fractured and the canal was widened.
Okay.
So you won't get a neurological deficit with such a patient. Okay. So if I knew I could also add few slides on just how to read the cervical spine X-ray, like talking about what you are saying, alignment and whatever. If you allow me, I can just share
absolutely.
a few slides.
Yes, please.
Okay. Okay, hope everyone is seeing the slides. I'll just go briefly on X-ray. What we do when you are reading with ABCs. Okay, just one thing. These are slides from AO Alliance. So there are also ABCs like Dr. Ulrick mentioned. So when you are reading, you have to check for adequacy of image. That's the first thing. Then alignment, anterior and posterior element. You have to check for alignment. Then you check for bones, presence of absence of fractures. Then C, cartilage. When you're talking about cartilage, you see the joint space. You see also the intervertebral disc. And the last one is soft tissue. So you check the soft tissue anterior to the vertebra and also the interspinal space. So ABCs of the spine. It's always better to look at this. And for cervical spine, for cervical spine, usually in trauma, we like to order, to request 3 views, the AP, anteroposterior view, the open mouth, and the lateral view. and also for dynamic one to check if there's instability or not, you have to order these flexion and extension views. Then there is also what is called swimmer views. This is just for patient when you are not able to see, like people with short neck, and you do, usually what we do in X-ray. At our center, let me say hi to Dr. Ashela, who is with us here. He's my colleague. He's also final year neurosurgery resident at the University of Zimbabwe. Good evening, Dr. Ashela.
Good evening. Thank you. I'm pleased to be here.
Thank you.
So,
thank you. The swimmer's view, it's only when you have a patient, usually what we do at our center, when you are sending a patient and you see that the patient has a short neck, maybe you are not going to see, because the first thing you are seeing on the X-ray, you have to count the vertebra, especially here I'm talking about cervical spine. You have to count from C1 to T1. If you are not seeing T1, you have to repeat that X-ray, because most of the fractures occur at the lower segment between C7 and T1. So if you order an X-ray and you are not seeing T1, you go, the first thing you do is to pull the shoulders down. You pull the shoulders and you screen, you check. If you are not seeing T1, you can do the swimmer's view, the one I'm showing there. That will allow you to see T1, C8 and T1. Then, so this is what I was talking about. Ensure visualization of occiput to C7T1. Then, like I was talking about alignment, see on C-spine, I'm just talking about C-spine. C-spine, you have to check the anterior vertebral line, the posterior vertebral line, the spinal laminar line, and the posterior spinal lines. Posterior spinal line is the line which is like going through the spinous processes, at the tip of spinous processes. And here, those lines, they have to be very smooth. If you see like there's a step deformity, then you check what is wrong there. Like this is just a diagram and the real X-ray is on the right. You can see the anterior vertebral line, the posterior vertebral line, spinal lamina. This is the line just going through the lamina, between the lamina and the spinous processes. Then after that, after adequacy, alignment, then you go through bonds. You check the bonds. Dr. Ulrick mentioned already this. You can see the C2, C3, C4, C2 with the spinal process. And this is the pedicule, this is the lamina and spinous process. You see there the facet joint, because it's very important when you are looking at an X-ray to check if those facets are very well aligned, because sometimes you can get jumped facet or locked facet. Then like this one, this is just an example. You can see the first one, this is an hangman fracture with a pedicule fracture there. And here, there's a facet fracture. And the last one, there's a fracture of the C3 body. So the soft tissue are also very important. Like I'm going through those ABCs Dr. Ulrick mentioned already. Now, there is what is called nasopharyngeal space, then retropharyngeal space. The nasopharyngeal space is between C1, it's anterior to C1. So it has to be less than 10 millimeters in adult. And the retropharyngeal space is between C2 and C4. And it has to be less than 6 millimeters. Here we are talking about soft tissues. And you take from the dark area, because this is the pharynx, and you see this is air going through the airways. And those vertebral bodies are there. So you measure from the anterior aspect of the vertebral body up to the level where you are seeing that air, or the pharynx or larynx. Then the retropharyngeal space, it's between C2 to C4. It has to be less than 6 millimeters. And the retrotracheal space from C7 to from C5 to C7. In children, there has to be 14 millimeters. And in adult 22 millimeters. This is the open mouth view. When you are doing the open mouth view, you have to check, can you see this is lateral mass of C1 and the other side, and this is C2, the odontoid peg is there. So you have to check the distance between the odontoid peg and the lateral mass. And at this level, the limit of C2 to the lateral mass of C1, you have to measure also that distance. See what is happening here? Like when you here, just to check when there is a Jefferson fracture, which is fracture of C1, and you check the distance between odontoid peg and C1 at this level, and also between the lateral border of C2 and C1. Can you see what is happening on this picture? This is the odontoid process. This is the anterior arch of C1. This is the posterior arch of C1. And this is the C2 body. So there is a fracture there of odontoid peg. There's a classification, but since we have medical students, we'll just limit it by day. See now, after highlighting that, this is the peg and this is the body. See where the fracture is. So here we are talking now about bones. And there also there is this is traumatic spondylolisthesis, like Dr. Ulrick mentioned. You see there is an anterior slippage of C2 on C3, okay? And you can also classify, is it grade 1, 2, 3, 4, and so on. Yes, there's also fracture of the pedicle. This is a hangman fracture, fracture of C2. This is fracture of vertebral body. It is called teardrop fracture. See what is happening there? Teardrop fracture. Fracture occurring when you are doing hyperflexion. And also, if you see the facet, let me take the facet between 3 and 4. Can you see what is happening there? This facet, the superior articulate, is just on top of the inferior facet. But if you check here, that inferior facet is here and the superior is there. So the facet is jumped on top of the inferior one. So see what is happening there? So the facet is on top of the other one instead of being close. So yeah, that's what I wanted just to add on C-spine X-ray, just to say that what Dr. Ulrick mentioned was very, very important, to do the ABCs of C-spine X-ray. A, adequacy. A, alignment. B, bones. C, cartilage. And S, soft tissue. Thank you so much.
Thank you, Dr. Kabulo, for the acronym as well. That was fantastic, amazing. If there's any other comments, Dr. Robert, I see you're unmuted. If you have some comments, please go ahead. I don't know if you're speaking, but we can't hear you.
So Dr. Ashela, Dr. Toibo, if you have a comment.
Yeah, I'm just trying to unmute myself here. Okay, no, I don't really have anything additional. It was a wonderful presentation. Thank you very much to both of you. Maybe what I could ask you to, since you've decided to talk on it, maybe what and there was a very nice maybe you could just tell us what is the role of spans. If you could go back to that slide where you showed the open mouth that showed the Jefferson fracture. I think it's a good opportunity, since you mentioned that medical students as well, to just introduce us to the role of spans, to probably be a very clear example. Dr. Kabul.
Is it me or Dr. Ulrick?
It was on your slides.
Oh, it was.
There was an open mouth view where you were talking about the Jefferson fraction and the measurements of C1 lateral displacement in relation to C2.
Okay, let me go back to the slides.
So Dr. Toivo, that for the rule, what we would expect is for C2 to not go above the lateral margins of C1, right?
There's a specific figure.
Okay.
Yeah. So we say, let's just wait for the correct slide to.
Can you see it now?
No, it's not that one. No, it's not that
It's not this one?
Yes.
This one?
Yes, this one. I know.
Okay.
Back the previous one. Yeah, even this one. But I think the previous one is clearer, yeah, because it's marked. So what we are saying in the rule of Spence is that you don't want the total overhang C1 to be more than 7 millimeters.
Okay.
Total. So if you take the total overhang on each side, it's more than, to be specific, it's 6.9. If it's more than 6.9 millimeters, that is an indication that you have a fracture of C1.
Okay.
So it's called the rule of Spence.
Okay. Thanks, Doc. Thanks.
Just thought it's a good opportunity to also just highlight that.
Thank you so much. Yeah.
Thank you so much, Dr. Achela, Professor. So I hope medical students are seeing. Can you see what is happening on the left here and on the right? So you have to take these, you measure there and here.
Yes, it should not exceed 7 millimeters in total.
Then you give the sum of that. If it's above 7, then there is a fracture of C1.
All right. Thank you so much.
Thank you very much.
If there are any questions, please ask the questions. After this, you should be able to at least be comfortable with the basics of imaging of the spine. Don't be shy. If there's something you didn't understand, ask.
Dr. Kadu is saying he has a problem with his microphone.
Oh, wow.
Yes. Lauren, Keke, any questions?
So honestly, I don't have any questions, mostly because I was following, I think that's a good sign actually, that there aren't any questions, but I was following most of the lectures. It was very informative, and I really think I'm actually ready for the OSCE. Otherwise, okay. I took some notes and I'll have to go through the material again.
Awesome, great.
Okay, thank you so much, everyone. So we are sending back, we are giving back Dr. Ulrick to say something.